Welcome everybody to this webinar series, Europe PCR Online webinar series on microvascular dysfunction. This particular webinar is on microcirculatory remodeling as a cause of INOCA. INOCA, of course, being ischemia with non-obstructive coronary artery disease. So today we have the privilege of having a very distinguished panel with us. Javier Escanet, who needs no introduction and really organized this whole webinar series, and Eva Prescott, who is going to tell us some really amazing information about non-invasive assessment of coronary microvascular dysfunction. Now, the aims of this particular seminar are threefold. Firstly, to understand what causes microcirculatory remodeling. Secondly, and very importantly, for you to learn how to diagnose it in the catheterization laboratory. And finally, to review the value of non-invasive tests for its detection and perhaps monitoring once you have commenced therapies. So the first session and the first mini tutorial I will do, and I'm going to start by introducing the concept of INOCA. So if we could have the first slide, please. Now, INOCA is a spectrum of disorders. There was a time when we used to call this Syndrome X, and that really reflects how little we understood about the conditions that caused patients to have chest pain, but were then found to have non-obstructive coronary arteries on angiography. But over time, we've begun to understand that even cardiac syndrome X comprises a range of conditions, and within that are those conditions shown at the bottom of your slide, which are due to cardiac ischemia. We now understand the condition with even more granularity and realize that a large part of that are patients who have microvascular angina, angina due to microvascular dysfunction or remodeling. There are also patients who have epicardial coronary artery spasm, so vasomotor disorders. That's not going to be the focus of this talk, but will be covered in other webinars. Now, I think it's worth us reviewing briefly what can now be achieved in the cardiac catheter labs, and the advances that have been made in the adjunctive techniques we have to angiography have been tremendous in the last 10 or 15 years. The most common and the mode of testing, and the one that you'll be most familiar with, is when we test smooth muscle function or endothelium-independent function. And that's where we use adenosine as the vasodilator agent. Now, most of you who are listening in will be using this almost on a weekly basis, but primarily to assess the significance of epicardial disease. And in that case, it's fractional flow reserve if you're using adenosine, or the resting indices, IFR, and so on. But using the same stimulant, we can, in the case of non-obstructive coronary artery disease, assess microvascular function. And the two main measures that are made are coronary flow reserve, which I'll come to in a minute, and also more specific measures of microvascular resistance. Now, using the same measurement setup, but different pharmacological agents, we can also assess endothelium-dependent function. And for that, the agent that we use is acetylcholine. And again, a little bit more of that later, but acetylcholine is used to assess dynamic changes in the epicardial artery, which will be covered in a different seminar, and also to test dynamic microvascular function, which we will talk about later. So coronary flow reserve, which is the key measurement that defines whether a patient is thought to have microvascular dysfunction or not, is a ratio. It's a ratio of the maximum flow that can be achieved during hyperemia, which would be over and above what can be achieved in the life of a patient during the course of their normal day-to-day activities, to resting flow. And we've come to think of diminished CFR as being primarily an issue with a reduction in maximal hyperemic flow. In other words, that the microvasculature can't dilate adequately in order to augment maximal flow. And that indeed is the case, but that is one specific subtype endotype that we now recognize as structural CMD. And the simple classification in the cath lab is, first of all, you have to have a diminished CFR, flow reserve less than 2.5 to have microvascular dysfunction at all. And then the demonstration that there is increased resistance, that the minimum microvascular resistance is elevated, confirms the diagnosis of structural CMD. But it is also the case that there can be abnormalities of resting flow. There are conditions in which resting flow can be increased, and it is that increase that limits the vasodilatory capacity, and it results in a diminished CFR as well. Here, the characteristics are a low CFR, but a normal HMR or IMR. And we used to think that this was a limitation of CFR, that this wasn't a real phenomenon. But we and others have recently shown that actually patients who have functional coronary microvascular dysfunction and those who have structural microvascular dysfunction actually have very similar phenotypes. They have similar degrees of ischemia if you were to do a test such as a perfusion MRI scan. And if you assess their exercise physiology, it is similarly maladapted during exercise. And I'll take you through some of the observations that we made and we reported earlier this year. So on this slide, the lines shown in green are patients who have normal epicardial arteries and completely normal microvascular function. And if you look at the panel on your left first, which is coronary microvascular resistance, you'll note that these patients start with high vasomotor tone, high microvascular tone, but with progressive exercise. And this was supine bicycle exercise while they were undergoing angiography via the radial artery, that the microvascular resistance drops progressively to peak exercise. When you give a hyperemic agent, you see that drops even further. So there's a very nice dynamic range of microvascular resistance. Now look at the red line, which is those patients who have structural microvascular dysfunction. Their resistance stays pretty flat throughout exercise. And even when you administer hyperemia, the minimum microvascular resistance that's achieved is still significantly higher than patients with who we consider to be normal controls. Finally, look at the group who have functional microvascular dysfunction, those shown in yellow or orange, depending on how this projects for you. These patients have low microvascular tone at rest, and that's what gives them the elevated flow at rest. And as a result, their minimal microvascular resistance, even though it's normal, doesn't represent a significant change from the resting state, and that causes a diminished CFR. Now look at the panel on the right, which is simply central arterial blood pressure. And you see that in the groups with functional CMD or normal microvascular function, there's a slight increase in blood pressure with exercise, as you would expect. But in contrast, in those who have structural CMD, there's quite a dramatic increase. And this is an indication to us that this condition of structural CMD is really a part of a systemic vascular dysfunction process, and that the peripheral vascular dysfunction actually has a detrimental effect. So not only does your impaired microvascular function affect your supply, but your impaired peripheral vascular function by increasing afterload tips the balance further in an unfavorable way by increasing afterload. So if I go on to my next slide, I will just summarize some of our observations, which is to say that these patients with functional and structural CMD have quite marked abnormalities in the cath lab that we detect in their coronary microcirculation, but they also have profound abnormalities of the systemic vasculature. The structural group have very abnormal responses to acetylcholine, and the functional group seem to have highly increased nitric oxide synthase activity at rest. And interestingly, they all seem to have some abnormalities that are manifest as a progressive increase in NT-proBNP levels, as well as you go from functional to structural. So in the next minute or so, I'm going to talk to you about what we think the causes are before going on to Javier, who will focus on the structural group. So the functional coronary microvascular disease group have elevated flow or decreased vascular resistance at rest. This may be because of increased myocardial oxygen demand at rest, and it may also be because of NOS dysregulation. Now, we don't yet know how the functional and structural groups relate to each other temporally, but it may be that this is an early stage of the process that goes on to then become structural microvascular dysfunction. And in the structural cohort, there may be, again, nitric oxide synthase dysfunction, but there are vascular remodeling related issues that limit that minimum microvascular resistance. That can be intimal thickening, abnormalities of the vascular smooth muscle cells themselves, which may be hypertrophied, capillary rarefaction, and perivascular fibrosis, all of which we'll hear more about from Javier. And this has long been recognized and is very nicely summarized in this article by Kamichi Krier and Noel Berry-Mertz, where they spoke about smooth muscle dysfunction, vascular remodeling, and endothelial dysfunction, all contributing to the process of structural microvascular dysfunction. So I'll pause there and perhaps ask Javier and Eva whether you've got any thoughts or any questions you'd like to ask about these endotypes. Javier, I'll come to you first.
Thank you, Deepaka. Well, I think that the last slide that you have shown us actually it demonstrates the enormous variety of conditions that have a translation in coronary microvascular dysfunction. But as you have already mentioned before, perhaps the term coronary microvascular dysfunction is too vague because you have many specific mechanisms of dysfunction. So what it follows is that because you have a lot of different conditions triggering different pathways of microvascular dysfunction, you have to really understand and to search for a specific involvement of one of these pathways to understand what is the cause and how it can be actually addressed by medical treatment.
So, Javier, perhaps I'll pick you up on that and go straight on to your mini tutorial. Could you talk to us a bit more about the manifestations of remodeling as we can measure it in the cath lab, particularly?
Yes, absolutely. So, if I may have the next slide, please. So basically, following your very nice presentation, Deepaka, I think that what follows is how does this microvascular remodeling affects intracoronary hemodynamics? This is an important question because this is what will set the framework for really interrogating this with intracoronary testings. Now, once that we're using intracoronary testing, which indexes and what cutoffs should we use for diagnosis? And finally, what are the treatment and prognostic implications of this particular condition, which is structural remodeling of the microcirculation? Now, we're talking, of course, of modifications in these intramural vessels, which is extremely important, arterioles, which have the key role of regulating resistance in order to adjust myocardial blood flow to myocardial oxygen demands. And at the same time, you have the capillaries, of course, a very extensive network of vessels, which, of course, you have the very important role of interchange of oxygen and nutrients with the myocardium. Now, when we speak about remodeling, what we are talking is basically in a structural modification of this network. And you can see this very nicely with these micro-CT images of the left ventricular wall of swine model that has a model of hypertension, an experimental model of hypertension. You can see that actually there is a rarefaction, there is a loss of density of both arterioles and capillaries as part of this particular pathway of microvascular dysfunction. And also, if you look to the structure of these arterioles, you can see that they are thickened, and that therefore they may be narrow, so they have lower conductance than normal arterioles, and actually they may be hyperreactive as well to vasomotor stimuli. Now, it's interesting that when you look to this histopathological cut, you can see this blue stain surrounding the arterioles. This is myocardial fibrosis. And it's important to remember, and Divaca has highlighted this before, that in many occasions you have, in parallel to changes in the density and structure of the arterioles, you have this modification in the structure of the left ventricular wall caused by fibrosis. Now, several years ago, we investigated what was causing the modification of hemodynamics at the level of the coronary microcirculation. For that, we performed an investigation in patients who had cardiac transplantation. First, because they have a variety of degree of microvascular dysfunction, and second is because we had an ethical opportunity of obtaining biopsies in these patients in whom we previously we performed intracoronary testing. And what we learned is something very interesting. It is not only the narrowing and the loss of luminal wall of luminal area of the arterioles what causes increases in resistance or decreases in conductance. Conductance and resistances are inverse, as you know. It is also the loss of capillary density. And we know nowadays that there are a number of conditions where you can see a dramatic loss of capillary density. Patients who have myocardial disease, who have dilated cardiomyopathy, you can see this as part of many transformations associated with left ventricular hypertrophy and other conditions. So, key important aspect, conductance of the coronary microcirculation, or if you wish, increased resistance of the coronary microcirculation, denotes both changes in the arterioles, but also changes in capillary density. And that is the reason because the two tests that we use to outline if there is microcirculatory remodeling in the left ventricle are, on one hand, coronary flow reserve, that of course is limited by the two mechanisms outlined before by Divaca, and microcirculatory resistance. You have two different ways of approaching this. One is thermodilution and pressure. We have covered this in the previous webinar. And the cutoffs that we use for this particular approach is we take as abnormal a coronary flow reserve that is equal or less than 2, and abnormal a microcirculatory resistance that is higher than 25 units. If you're using Doppler and pressure, the cutoffs are slightly different based on the studies that have reported patient outcomes. The cutoff for coronary flow reserve is less or equal to 2.5, and the hyperemic microcirculatory resistance is more than 2.5 millimeters of mercury centimeters per second. So these are the cutoffs that we use regularly to investigate if we have microcirculatory remodeling in the patients. Now, in the next slide, I'm going to show you how this translates in a patient. For example, this is a female patient, hypertensive, left ventricular hypertrophy, chest pain. She had a positive exercise tolerant tests. And actually, at the time she had angina, she developed left bundle branch block. So you are going to witness here in the cath lab exactly what happens when this lady exercises, because the study that is being conducted in this lady includes the use of cycloergometer in the cath lab while we monitor the coronary flow, velocity, and pressure. So the lady starts performing some exercise, and the first thing we see is that baseline coronary flow velocity is rather high. Typically, this location of the lady will be around 20 centimeters per second. But what is more striking is that as she increases exercise, as we progress through the Bruce protocol, there is no increase in coronary blood flow. So in a very dramatic way, you can see that myocardial oxygen demands do not trigger an increase in blood supply. And this comes to a point where the lady has chest pain, and exactly like it happened in the non-invasive exercise and tolerance test, she develops a left bundle branch block. We stop at that particular point, and here you can see that a few minutes later, the left bundle branch block resolved spontaneously into a normal intraventricular conduction. Now, we performed in this lady coronary flow reserve, which was abnormal, and we also measured microcirculatory resistances that were abnormal as well. Next slide. In the next slide, we are going to see the same from the perspective of using thermodilution and pressure. Again, this is a female patient, hypertensive. She has chest pain and a positive exercise test. Now, this study was conducted at the time of performing the diagnostic angiogram. And here you can see, like it has been shown in the previous webinars, how we perform these thermodilution measurements, performing injections of saline at room temperature that are followed by this drop in temperature and estimation of what we call mean transit times. Now, with this technique, we found that this lady has a very low coronary flow reserve, 1.6, and very high microcirculatory resistance, 31 units. So if when we go to see the two patients together, you have two good examples of patients who have microcirculatory remodeling of the coronary microcirculation. By the way, in both cases associated to hypertension, which we believe is a very important cardiovascular risk factor triggering this problem. Interestingly, the first lady, you could see that one of the problems is that resting flow was high, and this probably was due to the fact that she had some degree of left ventricular hypertrophy, and as Dibaka was mentioning before, perhaps at the resting state, her myocardium was really demanding already a very high flow rate. And in the second case, you can see a situation where actually you have low coronary flow reserve reduction and high microcirculatory resistance, again with an IMR of 31 units. What we know is that this information has also implications in terms of prognosis. This is a very interesting study that looked to patients who have coronary vessels with FFR more than 0.80. And in this graph that you have at the left, you have a plot grouping patients according to normal or abnormal microcirculatory resistance and coronary flow reserve. And at the right, you have the Kaplan-Meier curves of cumulative MACE during follow-up in the 4 quadrants. Now, I have just focused in the quadrant of the two patients that we just saw before, the patients who have microcirculatory remodeling, the patients who have high resistance in the microcirculation, low coronary flow reserve. And as you can see in the survival curves that you have at the right, this is clearly the group that has more events in the long term. So identifying microcirculatory remodeling in patients with INOCA has certainly prognostic implications. Now, what we also know, and this is important, is that in parallel, this prognosis could be due actually not only to the presence of these changes in the microcirculation, but also by concomitant changes in the structure of the left ventricle. And in this case, again, I'm referring to the presence of myocardial fibrosis. And this is a very interesting work in patients who have control patients and patients who have heart failure with preserved ejection fraction, HFpEF. And what you can see immediately is that the degree of rarefaction that you find in these patients is higher, of course, in patients with HFpEF. In other words, the microvascular density is reduced in patients with HFpEF, but also, and there is a clear connection between the two, there is an increase in fibrosis. So something that in the future we will know with further studies is to understand is one that we have identified these patients who have a high risk in the long term. We can introduce any changes in the concomitant cardiovascular risk factors or introduce adequate pharmacological measures that have some degree of reversal of these changes in the microcirculation, but also to understand if we can also reverse the presence of these myocardial fibrosis, which of course has deleterious consequences. And I will leave it at this point and come back to you, Eva and Divaka, to have your reviews.
Javier, thank you very much. That was really, really nice. And it's amazing to be able to understand what the measurements we make in the cath lab actually mean. And I think your study of myocardial biopsies and detailed physiology is just so instructive. Now, we've had questions flooding in, actually, and they're really good ones. So if that's okay, if you're both happy, let's go straight onto them, because I think they're thought-provoking and really relevant to what we're talking about. So thanks, everyone, for submitting your questions. So the first question was from Krishna, and if I can paraphrase, what information can be obtained about the microcirculation from just standard angiography? And for instance, is slow flow indicative of microvascular dysfunction? And I'll give you my thoughts in a minute, but Javier, what do you think? Can we, without using pressure wires and all of these things, just use an angiogram to infer anything about microvascular function or dysfunction?
Well, I think that it is the sensitivity and specificity of just flow velocity at rest in the angiogram is very low. You could increase it if you repeat the angiogram after giving intracoronary adenosine, for example. And actually, there is a coronary flow reserve based on TIMI frame count that has been, described. And it is not, say, the ultimate technique, but it's something that has a particular value. Eva, what are your views about this?
Yeah, what do you think, Eva?
Well, we did a study once, this slow flow, because when you see it, you think, there's got to be some resistance there. We did a study looking at whether this could predict prognosis in patients. It was retrospective, looking through several hundreds of angiograms and seeing whether slow flow could predict any kind of outcome, and it couldn't. I mean, that's not to say that it's not measuring microvascular function, but I think that it needs to be validated, and just a coronary angiogram with a slow flow, it doesn't predict prognosis like the other measures do.
And likewise, we also have tried to assess the relationship between TIMI frame count and various sort of detailed indices of microvascular function and found no correlation at all.
So a good example for this, Divaka, is when you perform an angiogram in an athlete. I mean, sometimes you see that at rest, the flow is very slow, and you can see huge coronary arteries. But I bet you, I mean, if you see how the flow runs in this athlete when he's exercising, you will be really impressed.
So the answer, Krishna, is I think you still have to do these dedicated tests, and the angiogram alone doesn't give you the answer. But it's a question that does bother a lot of people. And interestingly, in the Covadis criteria, one of the criteria is coronary slow flow, and these are concepts that we might need to revisit and revise as we go forward. So I'm going to pick some questions. We may not have time to go through all of them. But here's a good one. Why is there a difference in the cutoff value for CFR when it's measured by Doppler versus thermodilution? Javier, this was on your slide.
Well, two techniques, the Doppler was introduced first. We use both of them. Obviously, for example, if you're performing exercise, like in the case that I showed you with this lady, Doppler is very convenient because you can see continuous measurement of flow. You don't have to make injections. So the example I showed you, I think it was eloquently a very nice one for Doppler. But in general, nowadays, we have wide availability of the pressure guide wires with thermodilution, with temperature sensors to perform thermodilution. It's very simple. There's even a more sophisticated approach to perform flow measurements, which is based on continuous thermodilution, which requires a special dedicated microcatheter, can be used more in the future. But for the time being, it takes just one day for the colleagues to learn how to use it and to be ready to perform measurements of coronary flow reserve and to measurements of microcirculatory resistance. And the console that we have nowadays, which is the Coroventis console, really facilitate things because it has dedicated presets, that will immediately bring you in an automatic fashion all the parameters you need.
Thank you, Javier. Eva, I'm going to put this next question to you, if I may. And it's a good one. How can cardiologists working in poorly resourced countries diagnose CMD? I mean, sort of preempting your talk in a way.
Yeah, well, yeah, I can answer that in later, but so far the Rolls Royce is the cath lab, and especially now that you're talking about distinction between different types of non-endothelial dependent microvascular dysfunction, I'm not sure we have correlated that in non-invasive low resource areas, but you certainly can, and I'll be talking about that. Come a long way with echo. But I would like to make a comment. Can I make a brief comment on the question before? Because you're talking about a cutoff and, of course, comparison between different methods, and that we also have to apply to the non-invasive methods. But I'd also like to make an argument that it's not, yes or no microvascular dysfunction. There's also a continuum, like any biological variable. We use a cutoff because it's practical. Probably in the future, we need to look more at a continuum of microvascular function. Coronary flow reserve.
Absolutely.
There are a lot of questions. Sorry to interrupt. There are a lot of questions about therapy, and maybe I'll just pick one that perhaps summarizes the questions that many others have asked. Asif asks, does it help in treating our patients with any specific medications when we get information about CMD endotypes? And if I may start by answering that or giving you my views on that, I think this has to be the way forward, because the early trials that have looked at therapies for CMD have taken all comers, and it's almost a syndrome X population. And if you take patients who have very different pathophysiological bases and give them one drug, it's highly unlikely. One size fits all is highly unlikely to be the answer, and that may be why overall these trials haven't shown any benefit. But I think we have to break the cycle of saying, why measure these, do these tests and stratify patients if there is no therapy? It's because until we characterize them like that, we can't come up with specific therapies. And one example of that stratified approach came from the CORE-MICA trial. It wasn't highly granular, but it was at least dividing patients into microvascular and epicardial vasospastic, and that showed that there were benefits. So there are lots of questions, but perhaps we'll come back to them in the next session, because I think this is a really good point, Eva, for us to hear about you and the non-invasive methods of assessing microvascular function or dysfunction.
Yeah, thank you very much, Divaka. And by means of introducing myself, as you know by now, I'm a non-invasive cardiologist with a great interest in microvascular angina, and also I've undertaken a large study of almost 2,000 women with angina, no obstructive coronary arteries, and followed them now for some time. And that's what a lot of my research and several of my slides is based on. But why are we here? You are both invasive cardiologists, and I believe a lot of the audience is also invasive cardiologists. And I would like to sort of illustrate why it's important that we have non-invasive methods. And that's simply because the vast majority of angina patients never reach the cath lab. So what you see in the patients that you're testing are the top of the iceberg, whereas the angina population as such is the whole iceberg. And most of the patients will never reach you, but they still have the same symptoms and need for management. And this is illustrated nicely in less than 10% of patients with angina have actually obstructive coronary artery disease. For instance, in the PROMISE trial, only less than 5% of the 10,000 patients were actually revascularized. And we would normally say that most of these patients, if they don't need revascularization, they should not go to the cath lab. That may change in the future when we got treatment of microvascular angina, but for now, those are the guidelines. And if you look at the blue bars there at your right, you've got those with typical angina, and even patients with typical angina who are elderly still are more likely not to have obstructive coronary artery disease than to have obstructive coronary artery disease. So obstructive coronary arteries are rarely the cause of the symptoms. Of course, we all know that. I'm probably preaching for the already convinced, but this is important because according to guidelines, these patients should go through non-invasive assessment, and they should rarely, as I mentioned, they should rarely be routinely referred to invasive assessment. So what do we do with these patients who have the same symptoms and are the same need of management? Well, there we really need to develop some non-invasive methods. And it's important to focus now to make sure that we're discussing the same, because endothelial-dependent and the vasospastic components of vascular dysfunction, coronary vascular dysfunction, cannot be assessed non-invasively yet. So what we're discussing today is the microvascular dysfunction, which is non-endothelial-dependent and which can be assessed non-invasively using provoking with adenosine or dipyridamole. So that's what we're discussing now. And basically, we've got 5 non-invasive methods that are possible to use. One is the transthoracic Doppler echocardiography. That's probably the most used method and the most documented method. It's well validated, and it has large prognostic studies also. The same is true for the PET, probably considered the non-invasive gold standard. There it's also well validated from large studies, and it's got prognosis data also. MRI would be beautiful if we could do it. Small studies are coming out indicating that it can be used for microvascular dysfunction, but it hasn't been standardized across laboratories yet, and there are not follow-up studies showing that we can use it. So I don't think it's clinical prime time yet. The same is true for CT perfusion. Probably will be there in a few years, but it hasn't been standardized, not across labs, and there are no follow-up studies. And that's also true for myocardial contrast echocardiography. So I'm only going to be discussing echo and PET and showing you the data on the validity and the usefulness of these. First of all, I think there are a lot of how would I say, prejudiced against Doppler echo. People think it's very difficult, you can't do it, it's not valid, and particularly with fat people, with more obese people, you cannot do it. But all of these are really not true. If you're good at echo already, it's not difficult to learn. Of course, there's a learning curve, but once you start doing it and keep doing it regularly, you will be able to do this with a high validity. What you have to do is you localize the LAD with a color Doppler with a high frequency transducer. And there you have it there. And then you find the diastolic flow with a PV Doppler. You get a nice flow, as you see there on this slide. And then you start your infusion of adenosine or dipyridamole, and you induce the maximal hyperemia, and you see how the flow increases. So this is a beautiful, high-quality image you have there. It doesn't always look like that. But then what you find is either here at the top, you see at the left you see the rest, and then you see the peak with a coronary flow reserve of 1.1, but a very nice quality study. And at the bottom you see a normal response with a coronary flow reserve of 2.4. So that's how you do it. And we've tried to validate this both in healthy young subjects and also in angina patients, normal angina patients with risk factors, diabetes, obesity, and so on. And we found that when we invite people back within a few days or a week, we're able to reproduce the test quite well. So we can reproduce it, and we can also, but there's a learning curve, and there are some tips and tricks to what you should be looking out for. Well, you want to keep the color Doppler, you want to keep it throughout the whole assessment. If you can do that, then you're sure you've got the same vascular bed, and you've got a nice flow there, as you see on your left there. And then you've got various degrees of lower quality studies there. Where if you lose the flow, people have to breathe, and sometimes that moves it out of the window, or different things can make it poorer quality. But in our large study, and that included, as I mentioned, almost 2,000 patients, we were actually able to measure coronary flow velocity reserve with these unselected patients in 97%. 97%, yeah. And this was with an excellent or good quality of the measurement in 89%. So that should, I think, one of the prejudices should should be put down. We were able to do that in all comers, and it should be possible for any good echo lab to do that. So what's the value in terms of prognosis? Well, most of the studies on echo have come from Italy because they use stress echo a lot. And they've been following their patients. And this is a study from Rosa Sicari showing that in 394 patients with no obstructive coronary artery disease, measurement of coronary flow reserve was highly predictive for death and myocardial infarction. And she's not the only one who's shown this. We did a meta-analysis of the studies, and they were quite consistent. At the top, you've got studies with patients with stable angina, and at the bottom, you've got other populations such as heart failure, hypertension, hypertrophic cardiomyopathy, and the picture comes across that whichever population you look at, impaired coronary flow reserve carries prognostic implications. So, and we also found that in our study, the iPower study that I described to you, in 1,800, more than 1,800 women who were all comers undergoing invasive angiography, all comers, we could measure their coronary flow reserve by echo, 97%, and this was prognostic of a combined outcome, if you can see there. So it's something that you can do. It is prognostic, and you may also be able to be guided by this in your treatment of the patient. Now, the other gold standard for non-invasive assessment is the PET, of course. Well, it's been called gold standard. I think echo may also be, just as good in good hands in able echo labs. But the PET is the gold standard. And a lot of the data that's been published on this is from Marcello Di Carli's group in Boston. And this is one of these papers. When he takes, he looked here at more than 1,000 patients with no obstructive coronary artery disease, and two points could be made from this, that it's very common to have microvascular dysfunction. 50% had a coronary flow reserve below 2. And also, we often say that this is a disease of the women. But he found that coronary microvascular dysfunction you see the same distribution in men and women. So it's probably just as common in men as it is in women. His group has also published prognostic value of measuring myocardial blood flow reserve. And as I mentioned previously, I think we should really be looking at a continuum of risk. When he split his coronary flow, myocardial blood flow reserve into 3 tertiles, you can see that there's a graded risk. With the more impaired your myocardial blood flow reserve is, the higher your risk of adverse outcomes. And this is hard outcomes. This was cardiac mortality. The same group also looked at, whichever, it's the same as with the echo, whichever subgroup you look at is consistent, whether you've got ischemia, low ejection fraction, diabetes, whatever you have, you see the same, that coronary flow reserve is an add-on as a risk marker. And interestingly, when we're discussing structural, as you've been discussing the structural cause of the microvascular dysfunction, that the group was also able to link impaired myocardial blood flow reserve to echocardiographic indices of diastolic dysfunction, and also prognostically to the future risk of HFpEF. So that's also a link between blood flow reserve and structural microvascular dysfunction. And so finally, we did also a meta-analysis looking at how can PET contribute, or how can we summarize the prognostic value of PET impaired flow reserve, and we found something similar, that both in stable angina patients without obstructive coronary artery disease, and also in various other patient groups, there was a consistent finding that impaired microvascular function adds as a risk marker to whatever condition you have. And I think that brings me to the end of the presentation of non-invasive assessment.
It's a great whistle-stop tour through the non-invasive modalities, and the prognostic data are really, really impressive, actually. What's also impressive is the rate that you reported of being able to get good Doppler signals, and that's a challenge I've had when working with my colleagues who often think that it's a much lower proportion. I may put to you one technical question that's come in from the chat, which is from Ilona regarding color Doppler. What kind of frequency and what view do you take the images in?
Well, usually it's sort of an adapted three-chamber view, and then you move up a bit. It's going to be technical. You move up a bit, and then you have to sort of angle it. You have to, and it's a high-frequency probe. But yeah, that's what I can say. You just have to practice, but you need a dedicated probe to do it.
Okay. Javier, if I could come to you now, we're moving into an era where when a patient first presents with chest pain, a lot of systems advocate going down a CT coronary angiography pathway. And if patients are found to have unobstructed coronary artery disease, are we going to be moving back to a syndrome X type era where they go, we know you don't have obstructive coronary artery disease, there's nothing wrong with you? How do you think we can get around that problem? I'm not hearing you, Javier, for some reason.
Sorry about that. Yeah, I think it's a very important point, Divaka, because CT angiography will play a more and more important role in the first step of diagnosing the presence of obstructive coronary artery disease. And as you say, what is very important is that you rule out that there are obstructive coronary artery disease. Next thing you should consider is that perhaps you have a non-obstructive cause, microvascular or vasomotor cause of this disease. So what it follows very clearly is that, for example, a very logical step will be that you then will go to any of the techniques that have been outlined by Eva, non-invasive, that explore first if you have microvascular remodeling, because as Eva has highlighted, with coronary flow reserve, what you get is information on the endothelium-independent pathway. It's nothing to do with vasomotor problems in the microcirculation. And then you could get some valid information of saying, well, there is something wrong. The picture of having someone with a normal CTA, coronary computed angiogram, and impaired coronary flow reserve, immediately places the patient in a complete different prognostic perspective. So, and it really, I think that motivates much more to look in depth to what happens in the microcirculation of these patients, both for symptom control, perhaps also for improvement of prognosis.
Great. Once again, we've got questions flooding in. And one of them relates really to what you've been talking about, Eva, which is, can all types of CMD be diagnosed by non-invasive methods?
No, well, the answer is no. We cannot do all the vasospastic. We cannot do, and even if in the future we need to have subtypes, endotypes, as you say, of the microvascular dysfunction, structural and functional, I'm not sure how we would be able to do that non-invasively. But I think we could start. Maybe the PET, maybe the baseline flow in the PET can be used. I don't know, but we're not there yet, certainly. But you might imagine. I mean, for me. You might imagine having a stepwise approach that you have non-invasive, the CTA or whatever you're doing, which shows that there's no regional ischemia. And then if the patient has enough symptom burden and so on, you can do the non-invasive microvascular. And then if that's normal, then you refer to invasive, to the testing also of the vasospastic and endothelial dependent components. I don't know what you would think of such a...
I agree. Obviously, Javier and I tend to deal with invasive assessment, and I think having a modality that can diagnose microvascular dysfunction by showing an impaired flow reserve is a tremendous advance, even if you can't do the sort of granular endotyping. Because if we are to do trials, for instance, of therapies, and we are to monitor these patients serially, it's difficult to bring them back to the cath lab. And so just for diagnosis and for monitoring, I think it's invaluable. Now, I've got a series of questions coming in about HFpEF and INOCA and microvascular dysfunction. And one of them is, how how many of the HFpEF patients have microvascular dysfunction? Is it all of them? And another related question is INOCA the actual cause of HFpEF? Javier, I'll come to you and then I'll give you some of my thoughts.
Yeah, thank you. I think it's a very, very interesting topic. Of course, the first thing we have to say is that we are starting to understand this and that there are many groups working on this. But what is clear is that there is a clear relationship between the development of microvascular dysfunction, particularly in patients who are hypertensive, and then maladaptive left ventricular responses of different ways. So the key aspect is that the response to hypertension is very heterogeneous in terms of these changes occurring at the level of the microcirculation, and then followed perhaps by changes in the amount of fibrosis that you have in the myocardium. And therefore, that's probably the reason, because it's so important to ascertain as soon as possible that this is happening, tagging the individuals where you have this problem. Because of course, what follows from that, the first thing is that you should have a much more perhaps aggressive control of your hypertension in those individuals in whom, the response has been, those changes preamble future changes in cardiac function.
Yeah, I agree with all of that, Javier. And the other thing that I might add is that we know about the association between HFpEF and microvascular dysfunction. It's been shown by many investigators. What is harder to know is the causality, because one thing leads to another and it's a bit cyclical. For instance, if you have impaired lucitropy and impaired relaxation, there's often subendocardial ischemia during exercise, which will impair perfusion, and then that goes in a cycle. The impaired perfusion and microvascular function alone predisposes you to subendocardial ischemia. So I think this is going to be a challenge for us in terms of establishing causality, but the fact that the two conditions are linked seems to be increasingly accepted and agreed upon.
If I
sorry,
think that perhaps very important, and particularly comes, from longitudinal studies based on PET, is that there are many group of patients, for example, obese patients, diabetic patients, hypertensive patients, where actually the insights that you get regarding the presence of structural microvascular remodeling identify clearly patients who are at a high risk. So not all diabetic patients have the same risks. The diabetic patients who have an abnormal microcirculatory function, they are at a particularly high risk. And as you say, irrespective that the links of causality are still unclear, I think that at this point we have the possibility of tagging individuals who have a particular risk, and that is important from a clinical perspective and also from a research perspective, because these are the patients where we will be testing new strategies.
So there are, and I do apologize if you don't.
I'm sorry, can I make a comment on that also? Because in our large study, we found that it's intriguing, the link between INOCA, microvascular dysfunction, and HFpEF. It's really intriguing. But there's no doubt that you can have microvascular dysfunction without having any. A lot of our patients had microvascular dysfunction, and they had absolutely normal value indices of diastolic function. So it certainly can. You can get it before you have, so it's not just secondary to HFpEF. Another point is that we found that there's something we haven't discussed. Inflammatory markers in those with coronary microvascular dysfunction were elevated. We looked at a whole panel of 90 biomarkers, and they were elevated in a lot of this. A large proportion were elevated in those with microvascular dysfunction. So that's something we're going to be looking into in the future also, I think. What's the role of inflammation in this disease, and can we target inflammation?
Absolutely.
Yes. I mean, that leads on to some of the other questions. What are the therapies? We hadn't tried to cover the therapies because that will be beyond the scope of this webinar. But there is a session, which is session 6 in this webinar series, which talks about stratified treatment in INOCA. And I would urge you all to go to that, because they'll deal with therapies more specifically there. Now, in terms of diagnosis, there are a few questions that I can probably group together. Malwaisi, if I may if I have pronounced that right, asks if there's an imbalance between CFR and IMR, what do we do for diagnosis? And there are other questions about patients who have discordance. And I think discordance is perhaps not the right way to look at it, because it's not that we classify patients as having microvascular dysfunction by either index, but both bits of information are complementary, and using them both together can give you the fullest picture. And apart from technologies where you just have a Doppler only guide wire, for instance, whenever you measure microvascular resistance, by the nature of the investigation, you will always have a coronary flow reserve as well. If you do a thermodilution study to measure IMR, you will have CFR. And similarly, if you use a Doppler-based wire, combo wire, and measure HMR, you will have CFR. So I think it's a good idea to use both. And I'll show you a schematic that we use in my hospital where I work at Guy's and St. Thomas's Hospital in just a few moments to show you how we combine those elements. There are, so again, there are lots of questions. Is there much more that we can do than manage risk factors? But I think we'll come to that. And what about autoimmune diseases is another question, Eva, which speaks to the point you made. How much experience in this subset of patients?
Well, it has been shown that the patients with rheumatoid arthritis and psoriatic arthritis, that they have impaired coronary flow reserve. Yeah. So I'm sure that there's, and this links perhaps also to the issue of systemic inflammation.
Yeah, absolutely. And I think that targeting inflammation is potentially a really key area.
Probably, Vaka, something that we could say, just to say one word about treatment on this specific aspect, that is structural remodeling, is that, as illustrated in the case that I showed you of this lady who was unable to increase, blood flow, the first approach is to, in these patients, is to reduce oxygen consumption. That is the easiest way, to try to bring some relief. Because remember, you can see coronary flow reserve as a sort of index that tells you about dynamicity of the microcirculation, which was impaired in these patients, and you can see also resistance and something that informs you on the vascular network, the status of the vascular network. So I think that the basic approach in these patients is first try to reduce oxygen consumption, and then, of course, depending on the concomitant disease, etc., you may have concomitant treatments.
Yeah, I agree, Javier. I think we have to use the information that we're getting in the cath lab to try and guide our therapies, and until the trial results become available, that is a good interim step. But of course, we then need to check that approach of using a physiology-guided treatment algorithm is effective. So I think we're probably going to have to wrap up, although there are lots of questions coming in, and thank you for being so interactive, everyone who's listening in. But if I may just conclude with a couple of comments. So there were questions about guidelines, and do they need to be modified to make sure more patients get to the cath labs, or indeed have non-invasive testing? And I think those guidelines are being changed already. The 2019 update of the ESC guidelines gave guide wire-based CFR and microvascular resistance measurements a 2A indication, which is a step up. It used to be 2B. And I've crossed off or for the same reasons that I've just explained to you. I think those are complementary measurements, and you shouldn't try and classify patients using one index alone. We've heard really eloquently from Eva how non-invasive techniques can be really useful, either as a gatekeeper, as the first test that you do, or once you know that you've got unobstructed coronary arteries, to monitor the response to treatment. We haven't in this webinar spoken about intracoronary acetylcholine, and that will be covered in a subsequent webinar, which I urge you to go to. And this is the algorithm that we tend to use in our institution. So a patient who comes to the cath lab who's found to have no obstructive coronary artery disease will have a coronary flow reserve measurement, adenosine-based assessment. And if they have impaired flow reserve, then we make the initial diagnosis of CMD. and then use the microvascular resistance test to stratify them into structural and functional. If they have normal flow reserve, we go on to test endothelial function by looking at acetylcholine flow reserve. And you've also got to remember that coronary vasospasm can be a cause of angina in patients with unobstructed coronary artery disease. And only if they don't have any of those tests being positive do we send the patient away saying, you have normal vascular smooth muscle and endothelial function. Now, all of that will be covered more in these seminars. And thank you once again to the panelists for your time, to Abbott Vascular for sponsoring this, and without them we couldn't have done this, and to all of you for being a superb and interactive audience. Thank you.